So working in an acute hospital, it's not uncommon to see people who have a diagnosis of incurable disease. So one example of that is a chap called Russell who had come into the hospital earlier for surgery, had a mass on his lung, and they opened him up and then they closed him up again because the cancer was really extensive and they weren't going to manage it surgically. So he went home for a little while, and then he deteriorated a bit, and he came into our general medical ward where the geriatrician asked myself as the OT and the physio to do a screen and see how he was managing. So one of the things that happens in when you're seeing palliative care clients is sometimes a blurring of roles between disciplines, and what the physio and I decided to do was to see Russell together and to do a joint assessment, and we decided to do that for several reasons. One, Russell was fatiguing really, really quickly. He had incident pain, so pain when he was starting to move. He was also getting rather short of breath now. So we decided to assess him together so that we didn't have to duplicate the questions and that we weren't going to wear him out so much. We also were able to see Russell with his wife. Sometimes you can see someone with a family member if they're present. Not always, but this time we were able to see Russell with his wife. And again, that was really helpful for us because his wife was able to fill in some of the gaps. And again, it's not uncommon for a person to present themselves as managing perhaps better than they actually are. Not because they're trying to be deceptive, but they are wanting themselves to be better than they are, or sometimes they don't have the insight. So there can be a range of reasons. But so when we met Russell and Pam together, what became apparent was that Pam was actually having to provide increasing amounts of assistance in order to help Russell stand up from a chair, to stand up from the toilet and his bed, that he was becoming increasingly housebound because he was short of breath and he was fatiguing. So again, the physio and I finished that assessment, and we came back to see him the next day, partly so as not to tire him out and so that we could plan what we were going to do and how we could best support he and Pam. So when we came back the next day, the physio brought a gait aid with him, so a four-wheel walker, so that he could walk on, he could sit when he became short of breath, or he could rest his elbows on and he could brace himself. And she taught him some techniques to manage his shortness of breath. I'd brought some other pieces of equipment just to show him how they could help him stand from the toilet with less effort and move from the bed with less effort. The benefit for Pam was that that meant that she didn't have to help lift him enough. It's really common as allied health, when you're working with someone who's palliative, to have the doctor whip in and discuss something with the patient and then walk out. And that did happen with Russell, and after the doctor left, he turned to us and he said, "Am I dying? Is that what the doctor means?" So that was something that when we clarified if that's what the doctor had told him, and he said it was, that we then talked about what were the practical ramifications of that for him, particularly from a functional perspective, which was our focus. We also asked him whether, and he and Pam, whether that was something they'd like to talk more with somebody else about, and they said they would. So we followed up with the geriatrician on the ward and flagged the possibility of a palliative care consult, which can happen either with a nurse or sometimes a palliative care physician will come and just give some advice on how to manage symptoms like pain or shortness of breath. And they did come, and we were also part of that conversation so that we could then plan with the palliative care consult team how Russell might get home, because both he and Pam really wanted for him to go home, but he needed additional supports to do that. So I guess that's just a typical scenario of how you might have allied health liaising with palliative care, liaising with the physician on the ward. Social workers were also involved and helped plan and liaise with the community teams, so that when Russell and Pam went home to a situation that was going to keep changing continuously, and that's probably the only thing that was definite and that was sure that he would continue to deteriorate, that they knew there were some systems in place and that there was communication happening within the acute team and also between the acute team and the community teams.